Tonight's webinar will be presented by our musculoskeletal ultrasound fellowship candidate, Brian Cochran, and he has an amazing presentation coming up. I'm going to transfer the screen to him. Let me make him the presenter. Make presenter. So I just made you the presenter. Do you see the message on your desktop? Oh, got it. Good. We can see your screen.
Okay, very good. Let me see. Oops. Let's go back to the beginning and start this presentation. Hang on. What all are you seeing on my screen? Do I need to enlarge that?
Yeah, just go to slideshow. Yeah, the PowerPoint slideshow on top, the very top, orange bar that you see.
Okay, great.
No, yeah, or you can do that. Yeah, sure. From beginning.
Okay.
Yeah. Good, great.
Great. So as Mohini said, I'm Brian Cochran. I'm with Care Physical Therapy, and I am a HODS MSKUS fellowship candidate. And tonight I will be presenting cases in shoulder MSKUS as seen in our clinic. The first case came to us like you probably see in your clinic all the time. The medical diagnosis from the orthopedist was right shoulder pain, possible rotator cuff tear. The medical plan that he set forth was to inject the shoulder with cortisone, refer to physical therapy, and to follow up with the patient in 4 to 6 weeks or sooner if the pain increased. There was no plan for diagnostics based on his screen and his assessment, and this patient's insurance required, I think it was 8 visits of physical therapy prior to authorizing any further testing for possible MRI. The evaluation came to us as a 65-year-old female. She was very knowledgeable about anatomy and how the medical system works, as she is a nurse case manager. She's also a grandmother who assists with her grandchildren, specifically lifting, carrying, and assisting with all of their needs. And today, on this particular visit, she was assessed for right shoulder pain and a possible rotator cuff tear. Her active range of motion presented as forward flexion 110 degrees, abduction 95 degrees, external rotation 70 degrees, internal rotation approximately 25 degrees. And she came to us with a 3-month history of pain. Insidious onset, didn't really do anything traumatic, as she stated. Her strength was 4- out of 5, but she was limited by pain. Special test, she was positive for empty can for both pain and for weakness, and she had palpation tenderness in the anterior shoulder region and in the axillary region, with intensities reaching up to 6 out of 10 intensity. So coming into the office, she had fair mobility, she had reasonable strength, and moderate pain with no specific trauma. Being that it's part of our assessment now, I performed an ultrasound on this patient, and starting with our normal protocol for shoulder, we went straight to the short axis view of the biceps, and we start to formulate an impression off of both the short axis pictures and the long axis pictures, because to me a few things jump out, and I start asking questions based on these two pictures alone. Questions like, is there a bristle-like pattern to the biceps? Is this biceps tendinosis? Am I getting a good picture of the biceps seated in that bicipital groove? Is the transverse humeral ligament visualized? And in the long axis view, is there even visualization of the biceps? So I go back to those pictures just to kind of talk through a few of those. I do see something in the bicipital groove, and I don't see specifically a transverse humeral ligament. In that first view, 1A, as we're starting to formulate an impression, I look over on the lesser tubercle, and I don't really visualize, I see an anechoic signal here, and so we're already starting to form an impression as to what the next picture might look like. And in fact, that's exactly what we see in the next views. On the short axis and long axis views, we clearly see some cortical irregularities, In the long axis view, clearly there's a complete full thickness tear of the subscapularis muscle or tendon that's supposed to be present there. So again, here comes more impression off of the first two structures that we're analyzing. There's an irregular cortical surface of the humerus. There's non-visualization of the subscapularis tendon. We know that isolated subscapularis tears are rare. I believe the literature states anywhere, unless there's a specific mechanism for the subscapularis, apparently there somewhere between 12 to 20% of cases will just be an isolated subscapularis tear. So we can start to formulate, an idea of what we're going to see in the next few images. In full thickness tears of the subscapularis, sometimes we might see a migration of the long head of the biceps over the lesser pedicle, particularly in cases where the transverse humeral ligament isn't intact. And so in the next image, knowing that isolated tears are rare, we look for the supraspinatus. And depending on which margin you look at first from how you formulate your impression, I typically start at the cortical surface and work my way upward. Again, we see that there's cortical surface, and we see a lot of deltoid and subcutaneous, but not much attached there on that cortical surface. Okay, so non-visualization of the supraspinatus tendon. Again, seeing a complete full thickness tear of that tendon as well with associated cortical irregularities. Okay, infraspinatus. It's really hard when we're trying to come up with the current physiological state and we know what normals are. Well, to me, this shoulder just jumped right out at me, and we know that there's definitely some abnormality going on. And again, it's picked up here in the infraspinatus, non-visualization of the infraspinatus with cortical irregularities. We're also seeing the cartilage interface sign here as it kind of parallels the cortical surface. So again, formulating our impression, we have some pretty good ideas that it's going to look like some pretty good involvement. AC joint is the next image, and you can see here there's a narrowing of the joint space. Oops, sorry about that. Narrowing of the joint space, cortical irregularities, and you can see effusion. We're certainly not seeing, good spacing here. You certainly aren't seeing any cartilage in the depths here. And of course, with this little bit of convexity here, kind of picking up on some of the anechoic effusion surrounding the joint. The impression was there was a non-visualization of the supraspinatus tendon, subscapularis tendon, and infraspinatus tendon of the right shoulder at their attachment sites, suggesting full thickness complete tears with proximal retraction. There's effusion around the shoulder area extending anteriorly and posteriorly, and there's evidence of cortical irregularities in the right AC joint, suggesting arthritic changes. So when this patient came in, does this actually match and correlate with her functional mobility? I was surprised to pick this up with as much strength, and her assessment from her MD clearly was kind of along the lines of mine. Saw a reasonable range of motion actively and reasonable strength, and I certainly wasn't overly concerned that I would pick up on something so significant. So how is she able to function as well as she does? And should we be performing further assessments at this point? And as this patient was seen prior to our attending the mentorship and fellowship modules, I'm now cued in to kind of look for things like the rotator cable, which, thank you, Mohini, for allowing me to borrow your slides from your presentation. But what is the rotator cable? It's a band of transversely oriented fibers arising from the coracohumeral ligament, which courses posteriorly on the undersurface of the supraspinatus and infraspinatus tendons and terminates at the superior border of the teres minor. It's shaped like a parabola. It marks out a region of relative tendon hypovascularity known as the rotator crescent, where rotator tendon tears occur most frequently. an intact rotator cable could possibly attenuate or lessen the adverse consequences of rotator cuff tear on glenohumeral biomechanics. So being cued into this, was this intact in this patient? Could we visualize it? Here's what a rotator cuff, the rotator cable does. If you look the supraspinatus, the infraspinatus, and the teres minor, and as it's kind of that parabola shaped, it comes down and transverses the supraspinatus and then posteriorly to the infraspinatus. And you can see this cable is definitely, it's more of a ridge-like structure as depicted in picture 1A. Okay. The cable is a crescent complex, and I really like this picture because it likens it to this suspension bridge where the biomechanical load is transmitted to the cable, which if you know anything about civil engineering, you're always worried about the transfer of loads. And when there's moving forces working on it, like driving across a bridge, you need to make sure that you've got extra support. And this cable helps to distribute the stress to the humerus through its anterior and posterior bony anchors on the humeral head. So didn't see signs that this cable was intact. So is there anything else that we could consider? Well, I think the thing that jumps out to me was, is there any kind of accessory muscle groups that were, assisting with the strength test? Were we getting maybe a little bit of, possible biceps or deltoid? That's possible. But another structure that kind of comes to mind, thanks to Dr. Watt and her presentation, would be the superior capsule. The superior capsule is attached to the undersurface of the supraspinatus and infraspinatus muscle tendon units, and it resists the superior translation of the humeral head. Optimal repair of the delaminated tears include repair of both the underlying superior capsule and the overlying rotator cuff tendon. And so it's a very important structure when the rotator cuff is irreparable. In our clinic, we recently saw a patient who had a superior capsule repair because the integrity of the cuff was really poor. The supraspinatus was definitely retracted. And here's a picture of the capsule in its repaired state. So here you can see the normal, supraspinatus tendon attaching. Here you can see a major retraction, a tear, and kind of like loss of tendon coming over where it attaches to the humerus. And here's our repair. So in an unrepaired state, it looks very similar, but this is what they did in this particular case. And what it does, it prevents the superior translation of the humerus. So there's a good video in our slides that shows it prevents it from translating superiorly too far. And it's found naturally underneath, obviously, the intact rotator cuff. Interestingly enough, with this case, when we sent the impression of the ultrasound to the physician, he didn't quite believe that this was a full, complete full thickness tear for this patient based on how she was functioning. So it's led to our good discussions. In fact, so much so that he actually ordered an MRI, and I want you to read what the impression, I actually got this impression today, and it's pretty spot on to what we came up with. So number one, a full thickness tear of the subscapularis tendon with retraction to the level of the medial third of the humeral head. Number two, full thickness tear of the supraspinatus tendon with significant retraction medial to the glenoid rim. Number three, acute appearing full thickness tear of the infraspinatus tendon with retraction to the level of the glenohumeral joint and evident fluid and edematous signal in the muscle and musculocutaneous junction. Number four, I think this tells us our answer whether or not the superior capsule is intact. So this may be the only thing that I feel that the MRI might lead. It's associated findings including elevation of the humeral head with significant narrowing of the subacromial space. So possibly if the superior capsule is in place to prevent superior translation, and we have an elevation of the humerus here, to me, it tells us that that superior capsule may not be intact either. And number five is large joint effusion with fluid extending through the subacromial subdeltoid bursa as described. So,
Brian, just sorry to interrupt you. So so that's a very good point. But one more thing that we have to keep in mind is MRI is a static imaging. They're not doing any dynamic assessment. So whichever position the patient was laying down in the MRI scanner, they did that. And if you compare a healthy shoulder versus a shoulder where most of the rotator cuff is torn, you will see some narrowing and elevation. So but it may be functioning okay even with intact superior capsule or rotator cable. Just rotator cable and superior capsule may be enough for it to function okay, but it may still look bad on MRI.
Okay. Oh, thank you for that point and that reminder. Yeah. So I was just, not excited for this patient, but from a learning opportunity and from a case presentation standpoint, to actually take this to the orthopedist, who uses, by the way, he's a young physician who strictly uses ultrasound for guided injections. The fact that, a 15-minute scan could have saved him a whole lot of, cortisone and possible plan of care that's a little bit, to me, he missed it as well, and we could have caught that a whole lot quicker. Had he been more proficient with it, but I'm happy to do a scan, so it's led to some good discussions. Any questions on that? Any comments on the first shoulder case?
Brian, it's Vicki. I had one question.
Sure.
In your MRI impression, you commented that there was both anterior and posterior edema in the joint. Can you show me the slide that really kind of showed the anterior and posterior edema and how you kind of came to that conclusion?
Okay, so this is the MRI impression that probably gave you those specifics.
Yeah, when you on your MSK impression.
Okay. Yeah, so let me go back to those. Give me just a second. So for me, I can definitely comment on the anterior being in the AC joint. This would definitely be, did the impression say anterior shoulder, or did it say specific to anterior shoulder region?
I'm sorry, go back to your MSK impression slide for a moment.
Okay.
I need to reread it.
Okay. Fusion around the shoulder extending anteriorly and posteriorly. Okay.
Yeah, I was curious as to how, where and how I would see it posteriorly.
So let me answer that one, because that's a good, because Brian is, I think, showing only limited images. If you see the full scan, you will see fluid around, like in the first image, long head of biceps tendon. The sheath has some fluid, and then supraspinatus, although there's no tendon visible there, but you can see the anechoic signal just above the bone, so that's fluid. Yeah, so you can see anechoic in the long axis. Then infraspinatus, if you go to the infraspinatus scan, infraspinatus. Can you move to that slide, Brian?
Okay.
Can you move to infraspinatus slide?
This is infraspinatus long and short.
Yes,
Yeah.
yes. So here you can see you have cartilage interface sign. So you see cartilage interface sign when there is no tendon overlying the cartilage and there's fluid, and that's the reason you get the interface sign.
Yeah. So that's where you got it, that it was posterior,
Yeah.
and not just anterior, because I've seen it multiple times anteriorly, but
Yeah.
I had not seen the posterior.
Yeah, it tends to collect anteriorly more than posterior, but here, because it's a massive cuff tear, it's just spilling all around. In fact, in the subscap space, in the subscap image, the very first one, you will again see anechoic signal there. So wherever there is any space, any bursal space or a joint space, you will see some type of fluid collection there. And you can appreciate it more when you're doing active live scan. But even in these static images, you can see this anechoic signal right above the bony surface.
Thank you.
Good question. Thank you. No, thank you, Mohini. Any other questions on the? She threw me for a loop. I'll be honest with you. I was not expecting to see a complete full thickness tear, so it was just interesting to see the presentation. And
Let me ask you a question. Do you know the history of when did she receive cortisone injection? Like how frequently was it after she saw you or before she
She
saw
actually
you?
came to me after having seen the physician, and it was
Oh,
probably a week after injection that we saw her.
and how many injections she had?
Just one.
Or just one?
It's
And
a
do you know?
3 month history of shoulder pain that she really had insidious onset.
Okay. And the injection most likely did not help, right?
It did not.
It did not. Did it make it worse?
It didn't make it worse. I think
Oh,
her pain went from being kind of on top of the shoulder to more in the axilla and more anterior. So it did move, but it's certainly never resolved, and the intensity never got lower than a 6.
uh-huh. Yeah, another thing that you have to keep in mind, especially when you're treating patients like this patient, and you do examination and they go and get the injection done. Most of the time, the approach for injection is posterior approach. Some physicians inject in subacromial space, and some of them do injection posterior glenohumeral joint space. Sometimes patient has just the supraspinatus tear, and now because they did a blind injection from posterior approach, they get secondary infraspinatus tear. So that's another thing to keep in mind, especially if you're following up this patient. You do a repeat scan after, let's say, a month or something, and make sure you document that in your report and look for that.
Absolutely.
Yeah.
So in this case, I don't think, from a surgical intervention standpoint, he said you're going to stay functional as long as possible. And the outcome, he said, I don't think because of the size of the tears and retraction that I could even do any type of repair. We would have to do some type of reverse total shoulder, which does not depend so much on an intact cuff. And she's relatively young, and she said, no way, I'm still working. I'm going to stay as functional as I can. However she's doing it, I'm not sure how that is, but she is. And so that's where she is in this process. So, but really sweet lady, and we hope the best for her. The next slide, the next case is going to be yet another shoulder case that we saw in the clinic. And again, one of these presentations that came to us from who you would see in the clinic on a daily basis, just on a rather high pain intensity when she came in. But she was referred for right shoulder pain that began approximately a year ago, and she has a history of left shoulder calcific tendonitis. She was 56 years old, and she teaches aerial yoga and Pilates, which basically means her arms are always in an overhead position as she holds on to different type of trapeze and different, on the Cadillac of the Pilates equipment, and on some overhead trapeze that she does on a exercise tree, she calls it. So the direct access patient evaluation was seen by one of our therapists, and as you can see, forward flexion within normal limits or within functional limits with a painful arc. Abduction was within functional limits, again with a painful arc, around 140 to 150 degrees. Internal rotation was to her ipsilateral SI joint. External rotation was about 45 degrees. She had palpation tenderness of the right supraspinatus, infraspinatus, teres minor, grossly, pretty much anywhere this therapist touched, seems like she had pain, and she was very hypersensitive. And she had poor scapulohumeral rhythm with all active upper extremity elevation, as well as winging when at rest. Her strength was not tested due to pain, and posturally she presented with some forward head, rounding shoulders, and she was very guarded with all active movements. The therapist went ahead and tried to do some just kind of modalities in order to calm things down. They attempted 2 to 3 visits of PT, and there's some gentle mobilizations, iontophoresis, and a lot of ice, and a lot of patient instructions, as well as activity modification. She returns, and I happen to see her as she walks in. She's with her husband. At this point, he is a local physician. He's a geneticist. He's carrying her purse, I might add, and he's carrying a copy of her x-rays, some plain films that they had taken some pictures of after having seen the orthopedist. So anytime, the patient comes back and the husband is now accompanying, and he's looking for answers as well, and she's having pain on that anterior shoulder because she can't even carry her purse, we knew something was going on, and I wanted to know specifically. She couldn't move her arm, and performing any reassessment was nearly impossible because she was literally in tears. When she came in, she showed us these pictures, and I tried to scan in some images. You can see this calcification here, and you can kind of see it a little bit in this picture here. But is an x-ray going to tell us what we need to know, where it's located, what specifically is it? And the answer to that, obviously, is we need more information, and we have the ability to come up with some of those answers. So what is calcific tendinosis? What is calcific tendinitis? It's a condition that causes the formation of calcium deposits within the rotator cuff. Research shows a link between calcium deposits in tendons and diabetes and thyroid disorders, neither of which she has, by the way. The doctor may suggest a procedure called lavage, which involves inserting 2 needles into the tendon and rinsing the area with a saltwater solution. Ultrasound-guided percutaneous lavage and aspiration of the calcification is effective in improving their symptoms. And sometimes this condition can require arthroscopy with subsequent physical therapy. There are 3 stages of calcification. There's the pre-calcification stage, which the patient is asymptomatic. And the way I understand that is that the actual site where the calcification is going to occur, there are some cellular changes that happen there that predispose the tissue to develop these calcium deposits. The second stage is the calcific stage, and calcium is excreted from the cells and coalesces in calcium deposits. It begins to look chalky at this point. It's not a solid piece of bone. This is calcium hydroxyapatite, and it's formed from decreased oxygen tension and fibrocartilaginous metaplasia. And so now a resting phase begins after this, which is non-painful, and it varies in length for different patients. The next phase, which is the most painful phase, is the resorptive phase. The third phase overall, the third stage overall, is the post-calcific stage. It's a painless stage as the calcium deposits disappear and are replaced by more normal appearing rotator cuff tendon. So had our work cut out for her because she was in a lot of pain, and even tolerating the transducer on her skin was very uncomfortable. So it was a pretty quick screen. But what you'll see is, in our study, you'll see kind of a progression over time of how this patient presents. Calcific deposits mostly are hyperechoic with posterior shadowing. Small calcifications may be linear along the tendon fiber axis, or there may be amorphous appearance or globular with minimal or no shadowing. Increased flow on Doppler or color ultrasound around the calcification correlates with patient's symptoms and a higher likelihood of the resorptive phase, and that's that painful phase of the calcification. Here is our patient. If you are somebody who takes your studies from the cortical surface upward, in that short axis view, I was struggling to figure out, okay, where's my cortical surface? And in seeing that picture, this major calcification in this supraspinatus, you don't even see because of posterior shadowing the cortical margin. So it's a very large, painful calcification, and it also can be seen here in the long axis view. Again, we can see it in the oblique axis, and it was really just very impressive, for a lack of better adjective, calcific mass that was present in the surface, in the space. And when we're searching for normal, this was definitely not normal. We knew it was there because of the X-ray, and we were able to better localize specifically where it was. Again, here's the infraspinatus, the long axis view of the infraspinatus, and you can again see a calcific deposit or mass right here in the infraspinatus, as you can in this view. Again, in the short axis view, you can see the mass here, or you can see more of an amorphous shape where it looks a little bit irregular. And so I took a couple different pictures on this scan, and I believe this was in January when I did this scan. So the impression was there is a hyperechoic signal with posterior shadowing extending from the supraspinatus to infraspinatus, suggestive of a massive calcific deposit. Underlying supraspinatus and infraspinatus tendons cannot be visualized, and therefore the integrity of the tendons cannot be verified. Number two, there is sonographic evidence of diffused hypoechoic area at the proximal portion of the long head of the biceps, which we did not put in this slide, showing a loss of fibrillary pattern, which could indicate a biceps tendinosis or tendinopathy. And also not seen in my presentation is the hypoechoic signal around the AC joint, suggesting effusion. Okay, so that was so when I did these impressions on the actual of the cuff and our normal shoulder scan, I did not save any of the color images because I did not see, first off, getting her to hold still under the transducer was tough, but I did not see any kind of revascularization or neovascularization at this time. So in my slides, you don't see that specifically. So I can't comment specifically whether it was in the resorptive phase or if it, where we were in a stage, staging of this deposit, but we can definitely see it. Okay. This was from March 2018. And again, it does not look nearly as big as what we previously saw in our scans. You can definitely still see some anechoic signal here, and it appears to be an amorphous shape here that I believe is the calcification that was previously seen in our short axis view of the infraspinatus. And the same thing here, we can see some, amorphous structure, but we begin to see underlying tendon. So this is obviously a deposit that is shrinking in size in a relatively short time. 3 months, we're able to see this, which was pretty awesome for me to kind of watch this process. And again, you can see tendon here in the supraspinatus. Infraspinatus, we begin again to see tendon. We don't, it's kind of going away. This was September 3rd. This was on Monday. We wanted to kind of do some visualization. This would be 6 months after the screen, and I don't really see much deposit here. I see tendon. So this is some good news for the patient who is now fully functional and returned to instructing in Pilates and yoga. And again, here's a short axis view of the infraspinatus. You can now see the cortical surface. You don't see the posterior shadowing you previously saw. You can see tendon, and you can see the overlying deltoid as well, and subcutaneous tissue. Okay. Correct me if I'm wrong. I think we see a little bit of the calcific deposit here based on our scan that we did on Monday, but not nearly the size that we previously saw when we were looking at it in our scans back in January. Okay. Color assessment, you can tell me your opinion of this, and I'll tell you what I think, because I think, would this be considered revascularization, or is this technical, being a therapist who had too much coffee and is shaking as he's trying to secure the transducer on the head of the humerus? And the obvious answer on this one, if you watch, because you'll see the actual movement of the cortical surface, that don't get confused. This would be a technical error. So that's just movement of that cortical surface. So it's movement artifact. But the amazing thing is that she has returned to fully functional, and we were able to now witness the in fact intact tendon that was underlying a massive calcific deposit. Any questions on that?
Brian, did you treat her periodically during that time, or did she simply just come back in March and September for scans?
So I know her personally, and she has come back. She's always looking for advice for her clients, but also for herself. So we did treat with some light range of motion. She had a home exercise program, but really it was intermittent. It was probably twice a month, once every other week. And she was making strength gains and progressing appropriately. Her pain was way down. It was no longer, it dropped from a 9 to approximately 4 or 5, so we knew she was uncomfortable. Mohini pointed out that the area, as it doesn't appear that it's actually in the tendon, the area of this calcific mass appears to be more bursa in appearance. And I think if we go back to the original scans, we can probably see that.
I think the original scan is something that we cannot definitely say anything, because it's just blocking everything below deltoid. So it's the second scan, the second follow-up that you have, where you can see that the deposit is more in the bursal side. So here, if you define the infraspinatus superficial border, you will see that amorphous, especially on the left side, the LAX view. Superior margin of it's just above that amorphous deposit is in the bursa. So it's possible that the first stage where we are seeing a big block of calcium chunk that's actually is sitting on top of the tendon is not compromising so much of the tendon itself. Because when you see your last follow-up, which is a day, 2 days back, the tendon looks healthy and normal. Yeah, look at this tendon. It's a good looking tendon there. Most of the time when you have deposit in the tendon, it also affects the quality of tendon. So you see tendinosis type of picture in the tendon, even when the calcium is not there, it's post-calcific stage. But here the tendon looks healthy, so most likely it's just the bursa that was affected by the deposit. That's what I think.
Okay. Well, she's certainly feeling a whole lot better, and she was eager to demonstrate, because when I scanned her on Monday, she was eager to show off her new Pilates studio where she was doing all kind of aerial stuff. And I said, look, before you hurt something, let me scan you.
That's nice.
Really sweet lady.
This looks like a new shoulder.
Yeah, I mean, completely, healthy tendon.
Yeah.
Any
other questions? Sorry, go ahead. Yeah.
And so, would this still be some of that calcific deposit in the,
Yeah.
Okay.
I think this is post-calcific stage. It's still, body is still absorbing it, but there are still some left.
Sure.
Superficial to supraspinatus.
Okay. Very good.
But it's definitely less dense. And you're right, this is a motion artifact and the color assessment.
Okay.
Because if it was a true color signal, you would see it consistently in one spot.
Okay.
So the vascularization will be consistent in one spot. And another thing with vascularization, it also depends on the type of equipment you have and what type of mode you're using. Simple color ultrasound may not pick up very fine small vessels. You may need to use power Doppler. Some machines have, some do not have that. Power Doppler picks up even like small flow. But again, these are immature, tiny capillaries type of vasculature that forms in that area. It also depends on the angle of your probe, how you are positioned with respect to the flow of. So even if there is any type of vascularity, we may not pick it. There's always a chance that we are missing some of it.
Absolutely. Well, thank you very much for all the help, Mohini. I really appreciate it. It was a hard act to follow up Vicky's from last week, and I'm looking forward to Laura's next week. So thank you for all the help.
Sure, great presentation and good cases. Any other questions from or any discussion, any comment from
Good
anyone?
job, Brian.
Yeah, these were really interesting. Both of those cases were very interesting.
I would have never known, because the therapist who came to me, she said, this lady's in so much pain, or you have a history with her. Is she always this hypersensitive? And I said, no, she's really not. And I'm always of the opinion, whether it's pediatrics or if it's geriatrics, you take the patient at face value, and we could not understand why she was in so much pain and why she could almost not move the arm. And then when she came back with the x-ray, it was very interesting. My PT immediately said, I can see exactly why we need to localize where it is now. So ultrasound was very helpful in that case to localize it and kind of help her understand, and her husband, who was really appreciative as a geneticist. He was really into kind of the scanning process and the whole, where and how to focally localize, and was concerned that he was going to have to be taking his wife to get a lavage, but this fortunately resolved. So anyway, it was an interesting case for us in the office, but our PT was scrambling and couldn't figure out why there was so much pain involved with her shoulder. So
I think Dr. Brooks is attending through the phone. He texted, he sent a message, great presentation, Brian.
thank you, Dr. Brooks. I appreciate it.
Okay, very good. So thank you everyone for attending, and see you next Wednesday with Laura.
Oh, Jesus.
Here we go.